Okay, we are going to start out with the granulomatous reaction pattern, and I have 4 contrasts that I'd like to cover today, as well as a few other granulomatous entities in this section that are covered in the second handout I shared with you. So the first set of contrasts we're going to talk about is the contrast between xanthogranuloma and necrobiotic xanthogranuloma. So juvenile xanthogranuloma typically presents as a solitary, or you can have multiple papules or nodules. And so because these are papules or nodules, they tend to have more of a domed surface. So it's more convex in its appearance and low power. And you can see that there's an infiltrate that's filling most of the dermis and kind of tenting the epidermis upwards. The infiltrate tends to be fairly well circumscribed, as you can see, with a nice epidermal collarette that kind of borders the lateral aspects of this infiltrate. Another collarette there. The infiltrate is dense, so it's fairly packed. It tends to be diffuse, and it's comprised of epithelioid histiocytes. So remember, we discussed epithelioid histiocytes as being the constituent cells in a granulomatous infiltrate. These cells tend to have abundant eosinophilic cytoplasm. They have vesicular nuclei and prominent nucleoli. So if I go on high power, you'll appreciate these features in these cells. Lots of pink because they have a lot of pink cytoplasm. Okay. Admixed with these epithelioid histiocytes, though, are multinucleated giant cells that are of the same cell, so they're giant cell versions of the epithelioid histiocytes. And you can see them in this view here. You see multiple giant cells. What's characteristic about the giant cells in juvenile xanthogranuloma is that they tend to be of a certain type called the Teuton giant cell, which in its classic appearance is composed of nuclei that are arranged in a wreath-like pattern at the periphery of the cell. And then at the outer part of the cell, you have a foaminess to the cytoplasm that either is observable around the entire circumference of the multinucleated giant cell, depending on how it's sectioned. For instance, in this example, you can see the foaminess extends pretty much around that multinucleated giant cell, or you might just see it on one side of the cell. But in reality, that foamy change surrounds the outer perimeter of the wreath of nuclei. So this is what we call a Teuton giant cell, and it's quite characteristic for xanthogranuloma. It's not specific for it, though, because you can see it in other granulomatous entities. So you have to be careful not to eschew other histologic features that are typical for juvenile xanthogranuloma. The other thing you'll notice about juvenile xanthogranuloma is you don't have much of a lymphocytic infiltrate. There are a few lymphocytes scattered throughout this infiltrate, and you can see them particularly at the periphery of this histiocytic infiltrate. But you don't have dense aggregates of lymphoid cells. So you don't have lymphoid follicles forming. There might be plasma cells, but they tend to be few in number. Here we have some lymphocytes and some extravasated red blood cells. So you might see a few plasma cells. You might see a few eosinophils. So you can see other inflammatory cells, but they tend to be few in number. Okay, they're not the predominant infiltrate. And usually you don't see much in the way of fibrosis either, except in older lesions. And that's the general rule with granulomatous infiltrates is as they get older, they resolve and leave fibrosis in their wake. In this example, we don't have much in the way of fibrosis. So in summary, in juvenile xanthogranuloma, look for a diffuse but well-circumscribed infiltrate of epithelioid histiocytes with admixed two-tone giant cells characterized by your wreath-like arrangement of nuclei with foamy cytoplasm at the perimeter, and a very minimal admixed inflammatory cell infiltrate, mostly lymphocytes, plasma cells, maybe some eosinophils. And then on low power, recognizing the dome-shaped architecture of these lesions and the epidermal colorette is also helpful. Okay, let's contrast that with necrobiotic xanthogranuloma. Now, necrobiotic xanthogranuloma presents as a plaque-like lesion on the affected areas. Usually we see it around the eyelids or the upper torso. So head and neck region, upper torso are common areas, but the lesion morphology is more of a plaque. And so you'll notice that when you look at this on low power, that the surface of the epidermis is flat as opposed to the dome-shaped architecture we recognize for juvenile xanthogranuloma. And that's because the infiltrate in necrobiotic xanthogranuloma is situated in the mid to deep dermis and can even extend into the subcutaneous tissue. In fact, it frequently will do that. And in this example, the specimen is fragmented, but I do show you subcutaneous tissue with the granulomatous infiltrate extending into the subcutaneous tissue, which is typical for necrobiotic xanthogranuloma. Okay. The other feature you'll notice with necrobiotic xanthogranuloma is that the infiltrate in the dermis is still comprised of the same types of cells that we appreciated in xanthogranuloma. So you'll have epithelial histiocytes, and there are lots of giant cells, as you can see. But hopefully you can appreciate that there are these zones of collagen necrobiosis or collagen degeneration, where you have more of a paucicellular appearance, kind of has some pallor to it, and there's some increased white spaces, almost shaped like clefts. So these are called those cholesterol clefts that are classic for necrobiotic xanthogranuloma. You'll notice that we don't have a nicely circumscribed histiocytic infiltrate. Rather, the histiocytic infiltrate is organized as these bands, almost like a palisade. But when you look at the zones of necrobiosis, you can see that they kind of intersect a little bit at acute angles. So we talk about X-shaped necrobiosis as being fairly characteristic for necrobiotic xanthogranuloma, such that when you look at this on low power, you would appreciate that X-shaped intersecting quality of these bands of necrobiosis. Okay, kind of that X-shaped intersecting bands of necrobiotic or degenerative collagen. And then when you look in the necrobiotic zones, recognizing sort of the white needle-shaped clefting within those zones of necrobiosis is classic as well. You can see many plasma cells and you can see eosinophils in NXG. And I'll show you, so you just have to go, if we go a little bit further down, where there is a little bit more of an infiltrate. We can appreciate an admixture of lymphocytes, some eosinophils in this view, and plasma cells. So you can see quite a few plasma cells in necrobiotic xanthogranuloma. The infiltrate tends to be a little bit, the inflammatory infiltrate tends to be a little bit heavier in necrobiotic xanthogranuloma as compared to xanthogranuloma. You can see lymphoid follicles, although that's really not apparent in this example. just going to try to see if I can find a good focus to highlight a little bit more inflammation. And these are all, this is a zone that's showing mostly epithelioid histiocytes with admixed giant cells. So this is not a terribly inflamed lesion, but if you do have inflammation, you will see plasma cells, lymphocytes, eosinophils, and they'll be heavier. It'll be a heavier infiltrate relative to what you might appreciate in santhogranuloma. And those are the key features that allow you to distinguish xanthogranuloma from necrobiotic xanthogranuloma. Okay. Now, the next set of contrasts I want to talk about is necrobiosis lipoidica versus necrobiotic xanthogranuloma. So we just talked about necrobiotic xanthogranuloma. Let's look at necrobiosis lipoidica. Necrobiosis lipoidica is another entity that presents in plaque-like form. So when you look at it on low power, you're not going to have, a dome-shaped surface to the epidermis. It's going to look relatively flat because the bulk of the infiltrate really involves the mid to deep dermis and at times the subcutaneous tissue. So you'll see a fairly diffuse, dense infiltrate that's equally dense through the dermis, or it might be mostly in the dermis and not so much in the subcutis. You might have just a little bit of minimal extension into the fat, kind of similar to what we're seeing here. And it tends to be the portion of the dermis that dips down to form the panicular septae that is involved. The inflammatory infiltrate, when you look at it, tends to be arranged in a vaguely horizontal fashion, is the way I like to describe it. It looks like the tiers of a cake. So if you think of a cake and the layers, what you will appreciate with necrobiosis lipoidica is you'll have zones that'll look quite cellular because they are comprised of histiocytes, epithelioid histiocytes, and other zones that are relatively paucicellular. And they have kind of a fuzziness to the collagen because those are zones of collagen degeneration. And they kind of alternate between zones of cellularity, comprised of epithelioid histiocytes, and zones of relative paucity of inflammation with collagen degeneration. And when we talk about collagen degeneration, it can be evident as a subtle fuzziness of the fibrillary quality of the collagen to where you lose that detail to the collagen. So when you look at the collagen on low power, you can see a little bit of fuzziness to the borders of the collagen bundles. And that typically represents just a little bit of the collagen degeneration that we describe and that you can recognize on low power. So tiering of collagen necrobiosis alternating with zones of epithelioid histiocytes. Okay. And so instead of having smooth diffuse sheets of histiocytes, you're really having these horizontal arrays. The lymphoplasmacytic infiltrate in necrobiosis lipoidica is denser than what you see in NXG. So here we are. You can see there's a collection of lymphocytes and we can see admixed plasma cells, and you can see quite a few plasma cells here. You can see a collection of plasma cells right in this zone here. And there are a few more peppered in through here. These are all plasma cells. The bulk of these are lymphocytes. So you can see that that lymphoplasmacytic infiltrate is a lot denser than what we appreciated with necrobiotic xanthogranuloma. In NXG, we had clearer zones of paucicellular collagen degeneration replaced by cholesterol clefts, whereas here, you can still make out the collagen bundles. Okay, so the collagen bundles are largely still preserved, but you do have that fuzziness of the outlines of the collagen bundles. And you do have these zones of relative paucicellular infiltrates that allow you to contrast them from the other areas that are more densely cellular with epithelioid histiocytes. So while NXG has more clearly defined zones of collagen necrobiosis with cholesterol clefts, it's a little bit more subtle with necrobiosis lipoidica. And you obviously don't have cholesterol clefts in necrobiosis lipoidica. So once again, in summary, with necrobiosis lipoidica, you have more of a vague horizontal tiering of zones of epithelioid histiocytes alternating with zones of collagen necrobiosis, with in large part preservation of the collagen bundles. You don't have cholesterol clefts. You do tend to have a denser lymphoplasmacytic infiltrate. You can have focal extension into the subcutaneous tissue, and you do have admixed giant cells as well. So this is necrobiosis lipoidica in distinction to NXG. All right. The third contrast that I want to chat about is granuloma annulare versus necrobiosis lipoidica. So we just covered necrobiosis lipoidica. And let's take a look at granuloma annulare. So in granuloma annulare, you have complete and incomplete palisade. So you have ring-shaped structures. They may not be perfectly ring-shaped. You can have incomplete ones that are just arciform, or they just might be half of an arc. But they're comprised of epithelioid histiocytes, and they're situated predominantly in the superficial to mid-dermis. And they're best appreciated on low power. If you go in on high power on granuloma annulare, you will miss it. So it's really important to start out at low to medium power and try to appreciate these discrete collections of cells. There's one there. There's a smaller one there. There's one incomplete one there. There's maybe another one here. And they're just kind of distributed throughout the dermis. These are called palisaded granulomas, and they're characteristic for GA's kind of the prototype for palisaded granuloma. And they can be small like this. The palisades are made up of these epithelioid histiocytes, once again, that have abundant eosinophilic cytoplasm. You can have giant cells in that infiltrate, but centrally there's usually increased white spaces between the collagen bundles in the middle of these palisades. And if you were to get a mucin stain, you would be able to highlight mucin deposition centrally. So we talk about blue granulomas with GA, the blue referring to the blue coloration of the mucin. Here's a tiny palisade here with a little bit of collagen degeneration centrally. Moving along, here we have a much larger zone, much larger collection of epithelioid histiocytes organized in somewhat of a palisade. And then we have another palisade here with some, again, mucinous collagen degeneration centrally. There's another zone there. So in granuloma annulare, the epidermis is normal because the activity is really happening in the upper to mid-dermis. You don't have a linear arrangement of the epithelioid histiocytes. They're organized as palisades versus in necrobiosis lipoidica, we talked about the horizontal arrangement of the histiocytes. You do have focal areas of mucin deposition within areas of collagen degeneration. You don't have much in the way of plasma cells. There are lymphocytes, so you'll see lymphocytes kind of intermingling with the epithelioid histiocytes, or you'll see them around the blood vessels. But plasma cells don't tend to feature prominently. You typically don't see involvement of the subcutaneous fat unless we're talking about subcutaneous granuloma annulare, which is a variant of GA. And then in late lesions that are resolving, you don't have any sclerosis. It doesn't leave behind sclerosis as it resolves, okay? Which is the case in necrobiosis lipoidica. So GA prototypic feature are the palisaded granulomas versus the horizontal tiering of necrobiosis and histiocytic infiltrates in necrobiosis lipoidica, and the presence of mucin deposition within zones of collagen degeneration versus in necrobiosis lipoidica, you don't have that. All right, and then the last contrast that I want to chat about is xanthoma versus granuloma annulare. So xanthomas come in various types. This happens to be a xanthalasma. So this was a biopsy from the eyelid, hence the thinness of the epidermis and the multiple vellus-like hairs that are present. And you can see that there's a diffuse infiltrate in the dermis comprised of histiocytes. But when you look at the histiocytes, they're mostly foamy histiocytes, okay? So when you look in the cytoplasm, you see a foaminess with multiple vacuoles, tiny little vacuoles in the cytoplasm of these histiocytes. That is what is the characteristic feature of the histiocytes in a xanthoma, which stands in distinction to granuloma annulare, where you have your epithelioid histiocytes, but you don't have foam cells like these. You don't have any mucin or degenerative collagen in xanthoma. You typically don't have much in the way of a lymphocytic, perivascular lymphocytic infiltrate like we saw in granuloma annulare. You just have this diffuse infiltrate of foamy histiocytes. You can see them around vellus hair structures and just diffusely in the dermis. The histiocytes are often arranged in a perivascular or periadnexal pattern. So you can see that even though they're diffusely distributed in the dermis, you can see them sort of situated around blood vessels, kind of around adnexal structures. That's not uncommon to see that happening around blood vessels. So this is xanthoma, and hopefully easy to tell apart from granuloma annulare. Okay, so those are the four contrasts that I wanted to cover. Over the next few examples, then I just want to walk through a few examples of foreign body giant cell reactions. So this is, let's see, this is an excision specimen. You can see here, slide is a little dirty, here we go. Big excision specimen. And there's a dense, diffuse, and nodular infiltrate in the dermis. We go in higher power, and you can see that there's a nodular infiltrate comprised of what looks like lymphocytes on low power, but there are also these zones of fibrosis. You can see the linear arrangement of the collagen bundles and the intervening nodular infiltrate. So there's a little bit of fibrosis, which tells me this is a kind of an older lesion. When I look at the cells in high power, I can see they're very mixed, okay? They're admixed lymphocytes, lots of lymphocytes, but there are also histiocytes in here. So there are lymphocytes, there's some plasma cells, but there are these guys, these epithelioid histiocytes. And you see them throughout in the background with ample eosinophilic cytoplasm. And there are also these brown pigmented granules. And they're very coarse, they're clumped, and you see them both in the cytoplasm of histiocytes, but also just free in the, in the tissue. And this is tattoo pigment. So this person had a tattoo and had a very striking granulomatous reaction to the tattoo pigment. This is an old reaction because there's quite a bit of intervening fibrosis as well. There's quite a bit of fibrosis, even though it's so inflamed. So that tells me this is an old reaction to this tattoo, or it's been going on for a while. And you can see that there are quite a few plasma cells with their characteristic clock face nuclei. That's a perfect one there. There's another one there. And then lots of lymphocytes, obviously. So very polymorphous infiltrate, but the tattoo reaction was quite brisk. And here we have a sea of plasma cells. Look at that. These are all plasma cells. These are all plasma cells. So this is a tattoo granuloma, and this is another nice zone of fibrosis. Again, like I was mentioning, this is a foreign body reaction to tattoo pigment. Now, that was an older reaction to tattoo. This is tattoo pigment that's eliciting more of a gentler reaction. It's not as heavy of a granulomatous infiltrate. There's a lot of pigment, and you can tell it's exogenous pigment because it's heavy, it's clumped, large coarse granules. Nothing endogenous really looks like this for the most part. But if you look carefully, you'll see epithelioid histiocytes and some multinucleated giant cells, and they're trying to clean up this pigment. And this is a multinucleated giant cell here, and you can see it's got an asteroid body. These condensations of brightly eosinophilic material with the lacunae around them in the cytoplasm of the multinucleated giant cell. And you will learn that that is typical for sarcoidosis, but you can actually see it in any other granulomatous process. So it's not specific for sarcoidosis. But you can see that this is a fairly young reaction to the tattoo pigment because we don't have much in the way of inflammation. We don't have any fibrosis yet. So it hasn't been going on for a long time. But I just wanted to contrast that with the previous example. Okay, this is another, this is another example of a foreign body granuloma. So we've got an inked specimen, indicative of an excision specimen. So right away, you know, okay, this might be a re-excision of something. You can see the scar. But down in here, you can see some ovoid-shaped structures. And you can see a multinucleated giant cell infiltrate, investing and surrounding these ovoid structures. And when you go in on higher power, those geometric ovoid structures you can see represent suture. So this is a suture granuloma, another type of foreign body granuloma. And you can see all the foreign body giant cells coming in to clean up. And the nice thing with this is if we were to polarize this, which I'll show you, it's really beautiful. You can actually see the suture material polarizing beautifully. And you can see it cut longitudinally and in cross section. So this is your suture granuloma. Another common example of a foreign body reaction that we see commonly in the skin. Okay. Another type of foreign body granuloma that's also common is this one here. So we have epidermis here on top, right here. And we have a diffuse infiltrate in the dermis, okay, filling the dermis. And it's comprised of multiple multinucleated giant cells, varying sizes, and epithelioid histiocytes, but mostly giant cells. And in the cytoplasm of these giant cells, you can see these white spaces. Some of them have even needle-shaped configurations. So these giant cells are engulfing some material. And when you look in these white spaces, you can see strandy pink material in these needle-shaped clefts. So these needle-shaped clefts are not cholesterol clefts. They're actually keratin fragments. And here we have this huge blob of keratin. And then, you know, the giant cells are trying to engulf the keratin. So you'll see varying sizes of keratin fragments in the cytoplasm of these giant cells. And this is a keratin granuloma. Okay, so there must have been a ruptured cyst or a ruptured follicle with extrusion of keratin, and then you've got your granulomatous infiltrate coming in to clean up afterwards. So this is a keratin granuloma. Another type of foreign body granuloma that we see is this one here. And this is, here we've got some epidermis above, and we've got a little bit of a cystic structure here. But I want you to focus on these pale pink amorphous deposits in the dermis. We're going to zoom in on those. These pale pink deposits represent a gouty tophus. And when you look at them on really high power, at the fringes of these seemingly amorphous pink deposits is kind of a feathery appearance, as you can appreciate here. It almost has a cotton candy feathered appearance. That is what a gouty tophus looks like. And then in the surrounding these deposits, you have these epithelioid histiocytes. Okay, you have multinucleated giant cells in the background, lots of epithelioid histiocytes trying to wall off this amorphous pink feathery substance. And that is another type of foreign body granuloma, okay? So you've got, whenever you have exogenous or endogenous material that is extruded into the extracellular tissue where it isn't supposed to be, it will incite a granulomatous reaction, and that's what we're seeing here. So this is a gouty tophus, and that cotton candy pink feathered appearance is quite characteristic. So make sure you zoom in when you see amorphous pink deposits. Amyloid doesn't cause that, okay? Gout is the only thing that'll look like this. In alcohol-fixated tissue, you can appreciate more of a needle-shaped crystal formation of the gout, of the gouty tophus. But because this is formalin fixed, you lose that characteristic needle-shaped appearance of the crystals, but this feathery cotton candy appearance is really helpful to accurately identify this as a gouty tophus. And then another example of a foreign body reaction is this one here. So we've got epidermis, it's tented upwards slightly. We've got a nodular infiltrate in the middermis. And when you look at it closely, you've got this big white space. And then you've got this infiltrate sort of surrounding this white space. You have this fuzzy purplish basophilic-like material that's really just necrotic cellular debris. Okay, and when you look at the infiltrate, it's a little mixed. Let's see what we have. We have epithelioid histiocytes. We have some neutrophils in here. Epithelioid histiocytes, okay, they're the larger cells. We've got some lymphocytes. So very mixed infiltrate. And when you look in the center, we have fragments of what looks to be foreign material. This is actually plant material. And you can appreciate that cellulose structure. So this is plant material that has formed, that is inciting this reaction. So this is a wood splinter that's incited this reaction surrounding it, this foreign body reaction. It's really important when you have wood splinter associated granulomas or inflammation to get bug stains, special stains for bacteria and fungi, because they can be carriers for these organisms and can cause localized infections. All right, so that concludes a few examples of foreign body granulomas. The next entity I'd like to cover is granulomatous rosacea. So this is a punch biopsy. Obviously, it's from the head and neck region, and you can see right away on low power, all forms of rosacea share this feature, which is varying degrees of edema in the dermis. And you can tell that there's edema in the dermis because there's a bit of pallor to the dermis. It just looks a little pale pink. You can see the blood vessels are dilated. And there's somewhat of a diffuse infiltrate, but it looks to be centered around the hair follicles. So if we go in on higher power, you can see that there is a granulomatous infiltrate surrounding the adnexal structures. And these are histiocytes and multinucleated giant cells. And you can see them just situated around the hair follicle. In addition to that, you have the background edema, the dilated blood vessels, and perivascular lymphocytic inflammation. So the constellation of all of those equates to granulomatous rosacea. And there's an extreme variant of granulomatous rosacea called lupus disseminatus miliaris faciae, where you have frank caseation necrosis. You have a granulomatous infiltrate around the hair follicle, but it tends to be much more dramatic, dense, and you can have complete destruction of the hair follicle as a result of the caseation occurring. And the caseation simply speaks to the necrosis. It's a necrotizing granuloma. You can see sort of that amorphous pink, pinkish colored material, centrally surrounded by these epithelioid histiocytes. So similar to granulomatous rosacea, I like to think of it as kind of more an extreme variant of granulomatous rosacea with, you still have periadnexal, perifollicular granulomatous inflammation, but you have caseation centrally. And then the other entity that I wish to talk about is just the actinic granuloma, presents in chronically photodamaged skin, and essentially situated, the infiltrate is situated in the superficial dermis, and you have a collection of epithelioid histiocytes and lots of giant cells. You can see here. You can see that they're not really organized in a palisaded fashion necessarily. They can be sometimes, so it can be hard to distinguish this from GA. One thing that stands out about actinic granuloma of O'Brien is you'll see evidence of elastophagocytosis within the cytoplasm of the giant cells. So they engulf elastic tissue fragments. And so what you're looking for are these faintly bluish gray structures in the cytoplasm of the giant cells. An elastic tissue stain helps you appreciate it better, but we call that elastophagocytosis. And there's a great example there in the cytoplasm of that giant cell. You can see some fragments of elastic tissue fibers. So you don't, while you might have palisaded granulomas and actinic granuloma, you really don't have that mucinous degeneration of the collagen that we typically see in GA. So this is actinic granuloma of O'Brien, and I'll show you a, let's look at the elastic tissue stain. A common elastic tissue stain we use is one called Verhoef van Giessen. And you can see here on the Verhoef van Giessen stain, in this stain, the elastic tissue fibers are purple in color. But in the zones where you have the granulomatous infiltrate, you actually don't have, there's a paucity of elastic tissue fibers. And if you look at some of the multinucleated giant cells, you can actually see fragments of elastic tissue fibers in the cytoplasm of these giant cells. Okay, so this is a great example of an actinic granuloma of O'Brien. And then the last entity that I want to, or the last couple, this is an example of granulomatous cheilitis. So this is a biopsy from a swollen lower lip. And you can see that we have a diffuse infiltrate. You recognize, drawing your clues from what's around you, this is a salivary gland, okay? And you can see there's a diffuse infiltrate in the dermis. There's quite a bit of edema in the submucosa as well. And if you go in on high power, the infiltrate is very mixed. But what I want you to appreciate are these wimpy or wispy granulomas, as I like to call them. They are few and far between, and they're poorly formed. That's one there. That's one granuloma here with multinucleated giant cells and epithelioid histocytes. That's how small they can be and poorly formed. And they tend to be surrounded by quite a bit of lymphocytic inflammation. So you can see. Let's see if we can find another one. And they're just kind of wispy granulomas scattered throughout the dermis. That's another one there. You can pick them up because they're comprised of histiocytes, so they'll be pale pink in color, and you'll have this kind of aggregate of epithelioid histocytes and giant cells. Sometimes you biopsy granulomatous chylitis, and oftentimes you don't see any granulomas. It's really, these can be sparse and few in number, and so sometimes you have to get serial sections to appreciate or to find the granulomas. But this happened to be a really good example of granulomatous chylitis, and that's another granuloma there. These tend to be non-necrotizing granulomas or non-caseating granulomas, okay? And they're not sarcoidal granulomas because they're not naked tubercles. They do have quite a bit of lymphocytic inflammation around them, okay? So they're non-necrotizing granulomas, and they tend to be small and wimpy and spread out throughout the tissue with mostly a lot of background edema and a lot of lymphocytic inflammation. And then the last example I want to show is an infection. So infectious granulomas characteristically tend to be comprised of neutrophils. So you'll see granulomatous inflammation, but you'll see a lot of neutrophils. So in this example, we have a well-circumscribed nodular infiltrate in the dermis. And when you go in on higher power, you'll see these multiple foci of aggregates of neutrophils surrounded by granulomatous inflammation. So here we've got neutrophils, another collection of neutrophils. So you see these small collections of neutrophils surrounded by granulomatous infiltrate, and we call these suppurative granulomas. Whenever you see this, always think either deep fungal infection, atypical mycobacterial infection, nocardia, just think infection and get special stains to rule that out. And if you're going to look for the organisms, try to focus in on areas where you have most of the suppuration, because that's usually the highest yield for finding the organism. So I'll show you an example of the organism here. And hopefully you can see in this view here, there are these round structures. That's one example here, there, surrounded by white spaces. There's kind of a double wall structure here, a budding structure here. These are fungal organisms, and there's some more there, okay? So they're all over the place. The more you look, the more you see them. And focusing in and out can help you appreciate them better. There's another structure here. They tend to have kind of refractile looking walls. So focusing in and out helps you see them better and distinguish them from the surrounding cells. Okay. There's another structure there. So this is a fungal infection, and I happen to have a GMS stain. So remember, in a GMS stain, the fungal organisms stain black, and you can see how many organisms there are in there. And these are all budding, kind of yeast-like forms, as well as pseudohyphal forms. So this was an example of a deep fungal infection. I don't recall, this might have been Alternaria species. So Alternaria species typically presents with varying shapes of fungal organisms, of fungal forms. So This concludes kind of our quick overview of granulomatous entities. Thank you for listening.